Okay, afternoon everyone. So I'm going to give a talk about benchmarking in value-based healthcare. Just to clarify, what do I mean by benchmarking? I'm sure we're all familiar with the term. So to my mind, is we compare ourselves to others, find out who's doing well, try to learn from them. What is it about them, the other services that makes them perform well, and take that learning and try and improve ourselves, to be as good or even better than the best in class. So it's a way of improvements, really, benchmarking against others. Value-based healthcare. So we're talking really about, can we use outcome measures to benchmark? Can we benchmark according to outcomes? Clearly, when you benchmark, you have to choose a performance metric. Lots of things we can choose, but historically, as I'm trying to show on the next slide, we've tended to benchmark against things like waiting times. So generally access to care, access to healthcare. How long do you wait for your hospital appointment? How long do you wait when you're in hospital, in A&E, to see someone? Those have been the kind of traditional things we benchmark. And I guess there are reasons for that. And some of the reasons are we have the data is easy, readily available, and it's quite an easy metric to compare with. It's not too complex a metric. It's pretty straightforward. What's your average waiting time? There's other things we measure, things like infection rates, readmission rates, adverse events rates. All those things are important. But I guess what we have to bear in mind is the health service is set up to make people better, to improve healthcare, to improve health and well-being. Luckily, adverse events are very rare. So maybe we should be measuring, what's important to most people, which is, does healthcare actually work? Does it deliver what it sets out to do? Does it make you better? There's a quote on the next slide, which I've taken. Collectively, belatedly, we've recognised the most important issue facing the health service is not how it should be organised, financed, the structure, but whether it actually works. This is from 1997, which rather frighteningly is a quarter of a century ago. So this is not a new idea, to measure outcomes and to look at outcomes and to benchmark against outcomes. People have been talking about this for a very long time. So the question is, why can it happen now? Can it happen now? What's different? What's changed in the last quarter of a century? Is it because we're more enthusiastic, or we believe in it more, or because we're special? That's not the case. So why could it work now when it's not worked in the past? Well, one of the reasons on the next slide, I'm trying to talk about the tech, really. So we are now in a much better position to make the process of outcome collection easy, because unless the process is easy, people aren't going to collect outcomes. So in 1997, if you wanted to collect PROMs, it would have been a sheet of paper, and someone would have had to upload those onto a very basic spreadsheet, I'd imagine. I don't know if Excel was around in 1997, but anyway, you get the gist. Things have moved on. In 1997, to make a phone call, the phone would be very different to the smartphones we have now. So now we can collect things like PROMs electronically and make it easy for people to record outcome measures. Make it easy for people to display outcome measures and for people to see them without a huge amount of work, manual work. You've seen during the week, I guess, good examples of how outcome measures can be displayed and made easy. And I've tried to show this on the next slide. Just basic dashboards showing outcome results, and that can be at a patient level. This is a mock-up of how you might want to look at a PROM result in an IBD clinic, for example. I think you've seen other examples during the week of this, but this wasn't available in 1997. So if we go to the next slide, that's what gives us a little bit of optimism and hope that it's possible now, where it may not have been possible in the past. I guess it's the digital, the tech, and those developments that mean it is possible now to consider things like benchmarking according to outcomes rather than just, talk about it. The reason for putting this rather complicated looking blackboard was just to make the point, really. It's easy to say, measure what matters and we should focus on outcomes. No one's going to disagree with that. But when you get into the nuts and bolts of trying to put outcome measures together at a cohort level and benchmark according to outcomes, it suddenly becomes a lot more complicated when you put all this data together. Again, it's not a new thing to try and benchmark on outcomes. Next slide. I'm going back over a century now, when Florence Nightingale suggested we should benchmark according to outcomes, compare places on whether patients were relieved, unrelieved, or dead. You think the simplest measure there would be death. So, it's binary, you're alive or dead. What's your mortality at, I don't know, 3 months for a procedure? Either you're dead or alive. Now that sounds straightforward. As an outcome measure, it should be straightforward to benchmark against mortality. But it's complicated. So if you go to an individual clinician or an individual hospital and tell them that their mortality is high, their natural response will be to say, my patients are older, my patients are more deprived, or my patients are sicker. They've got more comorbidity, which isn't what this slide is trying to suggest. What we're talking about here is the importance of case mix variables. So outcomes, including death, are determined not only by the quality of care provided, but also the baseline health, comorbid conditions, and other characteristics. And a lot of these things are beyond the control of individual clinicians and healthcare, so it's unfair to judge against things that are out of their control. You just have to correct the data to take all these things into account before making big assumptions about mortality. So if you do go and say your mortality is high, and someone says, well, our population has a median age of, I don't know, 75, which is older than most other places, then you need to say, well, we've taken that into account, we've corrected for age, and still your mortality is high. So we need to be able to back up these outcome measures when we put them together and take into account other factors which will impact the outcomes over and above the quality of the care provided or the quality of the intervention. What I'm going to try and do is show you some real world examples. I'm going to show you an example from the kidney community now on the next slide. So, many of you will be familiar. What I'm showing here is a funnel plot. So the two lines, the shape of a funnel, and each dot is an individual centre. So these are kidney centres. The size of the centres vary. As you go to the right, the size of the centres increase. As you go to the left, the size of the centre decreases. That's important. So if you have a small centre, let's say you only look after 20 patients and one patient dies, that's significant. That's a significant proportion of your population. So these kind of funnel plots have to take that into account. So the funnels get wider as the centres get smaller to allow for that. If you're over the line, then you're an outlier. If you're below the line, you're an outlier. So you can be an outlier because your survival is too good. You can be an outlier because your survival is too bad. So you need to be between the lines really to not flag up as an outlier. Now what this data has already done is correct for age and gender. And you can see there are a few centres who are still outliers. So if we go to the next slide, they try to correct now for other factors which may influence mortality at 3 years. So they've now corrected for ethnicity and deprivation. Now I make it sound very simple, they've just corrected. But it's really complex, a bit of medical statistics to do this. And the degree of correction will depend on the techniques you use. So this is a real specialist area, adjusting for case mix. You need real expertise from medical statisticians to do this properly. But you can see what's happened there is less centres are now outliers. More centres are between the lines. If you go on to the next plot, they've now corrected for age, sex, ethnicity, deprivation and comorbidity. When you do all that, very few centres are actually outliers for mortality. Now this is really important because if you look at the first kind of chart, if you're one of those dots which have been identified as an outlier for mortality, then what happens next is your chief executive gets a letter to say, let's say your kidney centre has been identified as an outlier, you've got really high mortality, what's going on? I want you to do individual reviews of the notes of all the patients who've died and look for any themes or anything you could do better. That's a lot of work, so that has consequences. It has consequences for morale in the departments. You're identified as an outlier in a bad way and people are trying to do their best. It has consequences for the patients and their relationship with the units. A lot of data will be publicly available, more so than ever now, really. As soon as the slide is up, it's on Twitter. And so to be identified as an outlier has consequences. So if you are going to show and publish data, you have to be really confident that that data is robust and can stand up to challenge. So that's the importance really of adjusting for these variables, because getting it wrong has big consequences, because it's really important, when we benchmark publicly and tell people they're outliers, we've got to be really sure that they are actually outliers. And as I say, it's not straightforward. It's a complicated world, the world of medical statistics and doing this properly in a robust manner, but it has to be done. So that's mortality. So benchmarking against mortality can be done, but you've got to do it properly. Now, if mortality is complex, then clearly benchmarking against what matters to patients is going to be even more complex. So mortality is you're alive or dead. PROMs, I'm sure you're all very familiar with PROMs. So this is measuring what a patient's view on their healthcare. So PROMs can only be filled in by patients or their carers. It's their perception of, are they getting better? A doctor can't fill in how much pain a patient's in. It's up to the patient. So this is complicated. Obviously, you'll be on a scale of maybe 1 to 10, and there might be 15 different questions. So this isn't just dead or alive. This is a lot of questions you're trying to benchmark. Now, there are summary scores for some of the PROMs, which helps, but it's a lot more complicated. So what I'm going to highlight is a couple of areas you need to think about if you're going to benchmark according to PROMs, aggregate PROM data. What are the things we need to consider here? This is by no means an exhaustive list, but just some of the things you need to think about. What if we do nothing? Timing of collection, case mix, and dropouts. So if we go to number 1, what if we do nothing? What do I mean by that? We're generally very good at collecting outcome measures after an intervention on people who've had the intervention. We're probably less good at measuring outcome measures in patients who either are not referred to have the intervention or choose not to have the intervention. If we have people who have angina, stable angina, we may do an outcome project, and we'll probably be very good at collecting the outcomes of people who've had stents, but maybe not so good at measuring the outcomes of patients who either weren't referred for a stent or didn't have a stent, chose not to have a stent, or were turned down for a stent. But I'm trying to show here why it's important to know what happens to those patients who choose not to have an intervention. So if we look now, we're on the vertical scale, we have quality of life, and on the horizontal is just time. And let's say a patient has an intervention, a surgical intervention at time point A. And in general, that improves your quality of life. So your quality of life after, let's say, 12 months goes up to time point B. So you say that you assume then that the benefits gained in terms of quality of life is the difference between B and the baseline, which is point C. So you say you've gained B to C in terms of quality of life from that intervention. But what we don't know is what would have happened if you hadn't had the surgery. Your condition could have progressed. Your quality of life could have got a lot worse. So by a year, your quality of life would actually have been point D. So by going from B to C, you're underestimating the benefit of that procedure, in fact, and the actual benefit is between B and D. So that's why it's important to know what would have happened if you hadn't had the intervention. This is especially important where we're comparing, let's say, quality of life gains between different conditions, because some conditions will progress, others won't. It's possible some conditions may improve over time, and in fact, we're overestimating the benefits by comparing them to the baseline. So I think to do this properly, we need a really good idea of what happens to people who don't have an intervention. Now, that's not possible for everything. For a lot of things, there are clear guidelines to say you need the intervention, but for some of the things we do, it's not clear actually. There's a bit of equipoise. Is it going to benefit the patient or not? So it would be interesting if we did focus more on, measuring what happens to patients and the outcomes of patients who choose to have less interventions. So that's going to be important, I think, for the reasons I've outlined there. So that's what if we do nothing. This is the timing. This looks a bit complicated. It's not complicated. We have an intervention again. So on the bottom we have time, and the little a there is a time point where someone has a intervention. And if they have intervention A, then their health status, quality of life, is always better than if they've had intervention B. So, in kind of health economics lingo, A dominates B. So it doesn't matter what time you measure the quality of life after the intervention, A is always better than B. So in this case, it matters less, the timing. But what if we go to the next slide, and this is what happens. A gives you a short-term improvement, but then things deteriorate quite quickly. So you can see here it's critically important to know what we're going to measure the follow-up PROM. And are we going to measure more than one PROM because of these reasons? Because again, without understanding the natural history of the interventions that they're impacting quality of life, you may over or underestimate the benefit of an intervention. So you need a really good grasp, and this would probably come from other data and pilot data about what happens. You need a really good idea of what changes occur in quality of life, especially in chronic conditions. But this comes back to the question of, before embarking on benchmarking or outcomes, you've got to decide, what are we benchmarking again? What are we benchmarking for? Let's say it's a surgical intervention, a new hip. Are we using our quality of life metrics to judge the individual surgeon and the benefits of the surgery in the short term, or are we benchmarking the pathway or the rehab or the longer term benefit? Because you can see where you choose to measure your quality of life will change over time. So on the next slide is just saying what I said now, I think. This is from a realist evaluation of PROMs. And it's basically what I said. The example points to the issue regarding what aspects of care PROMs are intended to reflect: the skill of a surgeon, the teamwork and coordination of the operating team, the quality of care immediately post-op, or the quality of care received by patients in the community after surgery, including physiotherapy, etc. So the move in general, the mood music I hear is more about whole pathway. So you get around this by measuring for a long period of time, ideally pre and post-op, rather than just one-offs pre and post. But of course that adds another layer of complexity when we talk about benchmarking. So that's the timing of the measurement. The next question and thing I posed was about case mix. Case mix was complicated with mortality, for the reasons I outlined. Really, lots of things impact on your mortality. It's quite likely that even more things are going to impact on your quality of life scores. So adjusting for case mix in quality of life is going to be even more complicated. That's not to say it can't be done, it has been done. So what I'm showing here is a paper from the National PROMs programme, just describing the methodology they used to try and adjust for variables which would influence PROM scores. But before adjusting, you obviously need to understand what factors do actually influence PROMs over and above the quality of the intervention. And this is a paper just describing the methodology I think they were using to try and show what factors, how do you identify, we can all think of things we think would influence pain scores and anxiety scores over and above, the surgery. But this paper was doing it in a proper, robust fashion. The next slide is just going into a bit of detail on the methodology. So the kind of things, I guess if you're doing a study like this, you hypothesize and brainstorm and come up with a huge list of things you think might influence PROM scores or differ between centres. Here we got things like metastatic tumours, circulatory problems, comorbidity scores, ethnicity, etc. So I guess you get all of this data and try and see which of them actually independently does influence PROM scores, because ultimately then you're going to have to correct for them if you are comparing areas with high comorbidity versus areas with low comorbidity, similar to mortality. So when they did all this, you then finally end up on the next slide with a few things that influence. I think this was the Oxford HIP score. What variables from that huge list actually influenced the HIP score? I think COPD, circulatory problems, anxiety, depression, general health questions, deprivation. And then again, you do the complicated statistics so that when you're producing a funnel plot, like on the next slide, oh, sorry, not on the next slide. The point here is to show all of these things. If you're going to correct for all of these things and adjust your PROM scores according to them, then it's really important that all of these things are electronically available and linked to your PROMs collection system, which is what I was trying to show on the next slide, actually, that, you know, the databases all need to talk, because you're not going to do this manually. So if you find that comorbidity score or ethnicity or deprivation level influences PROM scores, and you're going to adjust your PROM scores by those factors, it's important that that data is all linked, because to do it manually is a huge job. You want your system to do it in an automated fashion, and then you can produce funnel plots. And again, similar to mortality, you know, if you tell someone they're an outlier, you've got to be really sure that what you're saying is robust, and it's not just because they look after people in a more deprived area, or maybe BMIs are very different. So again, you've got to be able to defend data when you benchmark according to PROMs, as was attempted here, I think. So yeah, the case mix stuff is complicated. Again, this should be more feasible and more doable in 2021 versus 1997. You know, I have learnt from experience that what sounds easy in the tech world is never easy. So, you know, trying to link data, and I've learned terms like FHIR and API, things I never heard of really. People have tried to dumb it down and describe things like, this is the letter, this is the envelope, or this is the socket, this is the plug, but I'd be lying if I said I really understood it. I just hope someone can sort it out. But it is really complicated getting all these systems to talk to each other, but it's going to have to be done if we want timely data. Those are one-off interventions. This is trying to standardize collection in a chronic disease. I think this is the ISHOM heart failure standard set. So the timing again here, as I said in earlier slides, is going to be really important. If you're going to try and benchmark heart failure outcomes, then you want to try and correct for all the case mix variables, the different types of heart failure, but also you want the timelines. You want a defined time zero. You know, you don't want to compare outcomes at 2 months in one cohort versus 12 months in another cohort. You have to compare like with like. So you have to have the timings of the collection sorted out. So again, this was just to show that people are trying to do it. It's not as if this is all hypothetical and we want to. People are trying to do this now and trying to do it properly, you know, collecting all the case mix variables, standardizing the timings. Well, what I'm showing here now is about the dropouts issue. This is made up data. This is not passing any judgment on any service like pulmonary rehab. So this is all made up. But let's say we were doing an outcome project in pulmonary rehab, for example, and you do a box and whisker plot like this to show that over time it seems like our quality of life is improving with our pulmonary rehab program. So again, you need to just bear things in mind when we look at data like this. You know, this might be a heart failure plot. It's really important to look at the numbers at the bottom. So we've got 250 starting at only 130 at the end. So the natural questions will then be what's happened to the other, you know, 120 patients? And someone might say, well, they were too breathless to come, or they were in hospital, or they died. So what could have happened here is, you know, all the sick patients have just dropped out. So nothing's changed in the good patients. It's just by dropping out the sick patients, your average scores, your median scores have gone up. I'm not saying that is what happens, but it's something we have to kind of consider and bear in mind when we track changes in PROMs over time. It's that people will drop out and the return rates are not going to be the same. It's a bit easier in, you know, one hit interventions like cataracts or hips or knees. You know, you'll get some dropouts and people refusing to complete or not wanting to complete or not well enough to complete. But it's more of an issue, I think, when we move into chronic disease, where it might be there are big differences in people who complete each time versus those who don't. And it might be not completing in itself is a case mix variable that we have to take into account. Yeah, so the dropouts, how we account for dropouts, it is complicated. You'd hope that, again, just adjusting for case mix gets around that, but just something to bear in mind, I guess, when you look at changes over time in chronic diseases and PROM scores. So those are some of the things that I thought you should consider as challenges, I guess, to benchmarking against aggregate outcome data. You know, making sure the data is robust and stands up to scrutiny, making sure you understand the trajectory of the disease, and just thinking about how you account for things like people not completing, and what would have happened if we hadn't done anything. But again, it's not to say it can't be done, because it has been done. So what do people do? What can we do with the data then, is the next question. You know, if we do all the work, get robust data sets, what's the potential use of the data? So if we had outcome measures across different areas, it might influence patients in where they want to get their treatment. This is from the King's Fund, again, over a decade ago. But one of the factors that will influence which hospital patients choose will be the impact on their health. You know, that's coming out top there, I think, is very important. So if we can show patients the potential outcomes, then they may use that to choose. Now, in the literature, there's some conflict over this, and I've tried to show this on the next slide. You know, how important is outcomes to patients? Although patients are clear they want information to be publicly available, they rarely search for it, often do not understand or trust it, and are unlikely to use it in a rational way to choose the best provider. Now, intuitively, you know, from a health economics perspective, you might think people will strive just to achieve the best outcome, best utility. But people sometimes don't behave as they should in the world of health economics. They may rely more on things like what friends tell them, what GPs tell them, previous experiences. And other factors will come into play, you know, such as the travel time, or whether you need to get someone to take you, or the cost of going on a train. So we can use them for outcomes to help patients choose, but we probably need to make the data more accessible and help patients understand sometimes some of these complex plots. But that's a potential use, you know, to help patients understand what centres offer. Clinically, obviously, it's important to understand your outcomes and how you compare to others. This is about informed consent. So if you're consenting someone to procedures in your centre, and you know, you probably need to have a good grip on how your centre compares in terms of outcomes to other centres. I think that's probably part of good practice, really. Yeah, so next. I started off by talking about benchmarking as a way for driving improvement. So there's a couple of ways benchmarking could drive improvement. It could, yeah, if you go back, Chloe. So we can either work collaboratively or work in competition to drive improvement. You know, there is that competitive edge, whether that's between clinicians or between centres. What the data suggests really is competition is more likely in places which are very close to each other, you know, the local derby, or when the number of people benchmarking is quite small. So if you only have a couple of centres and they're close to each other, you might get a bit competitive, and benchmarking may be driven more by competition and wanting to beat your neighbour. Probably collaboration is a better way of doing it. So if you want to benchmark for outcomes and drive improvement, again, what the data suggests is having more centres involved is important, because you get more collaborative. Meeting frequently and discussing findings frequently helps. And having centres sometimes which are far apart, you know, helps. And it may be international centres, or anyway, that's what the evidence suggests. If the more centres involved, the more dispersed the spread, the more frequently they meet, the more likely benchmarking is to drive collaboration rather than competition. And I suspect collaboration is going to be more productive in the long term, and it's going to sap less energy than competition. Yes, so on the next slide. So if we want to drive improvement, now if we get to the point where we can benchmark on outcomes, that's good. But what benchmarking on outcomes doesn't do is tell you why one centre is better than the other. And again, that was back to my original point really about benchmarking. If we're going to learn from the best centres, we need to understand the processes in those centres and how they're different to the processes in our centres. So this is where process measures are going to be really important. You know, there was a point where process measures became a bit of a swear word. It was all about outcomes, but it's not going to be all about outcomes. You have to use, you know, all of the measures available. So yes, one centre might have really good outcomes, but what evidence shows is that unless you tell people why and you understand your own processes, then you can't drive improvement. So outcomes are just one part of the story, really. You need the underlying process measures to drive improvement, so you understand why your outcomes are worse potentially. Because what evaluation shows is when you show someone they're an outlier, but don't help them understand why they're an outlier, they don't tend to take steps to improve it. And also people need the skills to drive improvement, and that's really a challenge, isn't it? Really, implementing change. We're all familiar with that, and implementing change in a healthcare system is a real challenge. So it's a skill. So we need to if we're going to drive improvement, we need to understand the processes that are different, and also have the people, the time, and the skills to implement change. The next thing is if we have the outcomes and we're benchmarking outcomes, can we use those outcomes to inform commissioning decisions? If we were to do that, there is a risk, and again, this is evidence-based, that if you pay for outcomes, you may get games being played. So, you may get gaming of the system. There's a couple of things that could happen. People might focus their efforts entirely on the things that are being paid for. That's effort substitution, really. So other things suffer, so you get unintended consequences. But also people might change their practice to maximize income. I'm going to try and give an example of that on the next slide. It's a bit blurry, I apologize for that. This is taken from a cataracts paper, I think. It's just to make a point. Let's say we have outcome measures for cataracts and it's a score. Let's make it up. If we say it's from 1 to 5, and let's say we decide we're going to incentivize outcomes and we're going to pay for the percentage increase in outcome scores. So in this example, blue is pre, green is post, and there's big improvements. But of course, if all your patients have a pre-op score of 1, which is the lowest score, then the average score post is always going to be higher. You can't get lower than 1. So there's that floor effect. You can't improve more than 1. And the minimum improvement is to 2, which is 100% increase, if my maths is right. So maybe Greg can check that later. But I think it's 100% increase. And that would mean if you were trying to maximize your income, you would focus your efforts on people with a score of 1, because you're going to be paid for your percentage improvement. Conversely, if you get someone turning up, a cohort whose scores are all 4, the most they can improve is 25%. The likelihood is that 1 or 2 may drop down to 2 or 1, and that will be a huge percentage drop. So your average percentage is a high risk of dropping, so you lose income. So by incentivizing that, there is a risk that you will deny care to patients. Now, value-based healthcare isn't about rationing. The focus is on shared decision-making and informed decision-making. Just because your pre-op score is relatively good doesn't mean you don't need the operation. You then need to ask why you're having the operation. And it might be you need cataract surgery because your hobby is playing cards, and it's really important to you that even though you're a score of 3, you would do anything to get to a score of 5. And there's a risk if we commission according to outcomes that you may be denied access to treatment that from a patient-centered approach you still need. So just need to bear that in mind, I think, if we attach pound signs to outcomes. And the next slide, this is just some real world cataract data, just to make the point that the better your pre-op score, the more likely it is to be worse post-op, which might influence commissioning decisions if you were being paid purely on outcomes. Yeah, and the next slide was an example of, I think it was after varicose vein surgery, possibly. We need to be a bit careful with the data that people might misinterpret and say, and once it gets out into the press, oh, we shouldn't be doing stuff. People need a really good understanding of why these things are being done before coming to conclusions around whether or not procedures should continue. Okay. So finally, I've talked about the challenges. I've talked about how we might use the data. Let's see what's been done already with using the data. Some of this is international stuff, really. This was purely a report on does publicly showing mortality data improve mortality, which is the hope, I guess. If you publicly show centre-specific mortality, it should improve mortality for the reasons I discussed about collaboration and competition and improvement. The changes in mortality were fairly minimal, actually, in this study, not huge. What about PROMs? this was a paper looking at the impact on hospital performance of introducing patient-reported outcome measures in surgery. The hope is obviously, again, if you display robust PROMs data, that will drive improvements in outcomes. But the improvements were slight on this, slight improvements in outcomes for hip and knee replacement, not for hernia, slight worsening for varicose vein surgery. The proportion of providers deemed to be outliers did not change over time. So why is that? If we look on the next slide, some of the reasons quoted in this paper was, one of the complaints was there are delays getting the data back, so the data is not timely. So if you get data from 2019 now, showing that you were an outlier in 2019, well, you're going to say, well, everything's changed now. We've got a new set of doctors in now. Our systems are all different now. So if the data is not timely, you're unlikely to respond to it. But there's a bit of tension there, because I've told you, this data takes a lot of effort to collect, manipulate, that's the wrong word, analyze, correct for, do all the statistics for. That's not a quick process very often. So there is a bit of tension between having the data that's robust enough versus also having data that's timely enough. There needs to be a balance, I think, between the two, and that's hopefully where the tech comes in. But obviously you need enough numbers for the data to be robust. So there's a bit of tension between the timeliness of the data and the robustness of the data set and the statistics. But one of the criticisms, I think, has been that data takes too long to come back from national audits. By the time it's back, a lot of the people involved are retired. A problem from this paper was a lot of the data was coming back as really complicated spreadsheets that people couldn't really make head or tail of, or didn't have the headspace really to go through, which is why, again, it's really important to have good dashboards and good visibility of outcome data. And also the ceiling effect is describing that, well, if actually an intervention we're looking at already has really good outcomes across the patch, then there's little role for benchmarking. If everyone's already doing really well, you're not going to gain that much from benchmarking. There's a little bit of ceiling effect there. Another paper on the next slide, this was in Ireland, looking at benchmarking value-based healthcare. The effectiveness of, this was a trial, I think, a kind of blinded trial, whether or not to provide peer benchmarked feedback to hip replacement surgeons based on PROMs. So you'd either see where you benchmark or you wouldn't. And again, the hope was this would drive improvements, but the outcomes for patients operated on were not statistically different from the outcomes of patients reported by surgeons who did not receive feedback. So showing and benchmarking didn't seem to drive improvement in this paper. And again, on the next slide, they tried to explain why. And often it was just lack of clinical buy-in. So clinicians didn't trust the data. You need your clinical teams to be involved in deciding what data is going to be collected and to get real buy-in, or they won't trust the data. This is the point I made earlier about lack of process data. So just showing someone they're an outlier without telling them or helping them understand why, as compared to good centres, doesn't drive improvement. And also this study suggested that data collection was so burdensome, it became very difficult. So again, we had to make it seamless, again, where the tech comes in, I think. So there's lessons to be learned from all these previous studies. This is the clinical skepticism, I think, just asking people, asking clinicians and asking patients, what do you actually think of benchmarking, I guess, or displaying data publicly? I think on the next slide, there's just a couple of quotes about concerns. There's concerns about it getting into the media. Politicians are going to play with them. Politicians are going to mess with them. It's classic fodder for the Daily Mail. People are already telling me knee replacements give no benefits to patients, etc., etc. So I wouldn't suggest enforcing outcome measurements on clinical teams without engaging on the why right at the beginning, really, or you're going to get people just finding reasons why the data is wrong, or why it doesn't apply to them. So if this paper was suggesting, really, if you just throw things out there and people feel things are imposed on them, you get a lot of clinical pushback and no buy-in, and people will find reasons not to engage or to rubbish the data. Okay, so this is my final slide. We want to use outcomes for benchmarking. If we want to use outcomes for benchmarking, we need to do a few things. We've got to choose the right conditions. As I said, there's no point choosing a condition where everyone's doing brilliantly. You need to think which conditions do we think there is some variation in practice, and where are we going to get the most bang for our buck initially? The data must be trusted for all the reasons I've said. It's got to be trusted and stand up to rigorous scrutiny, especially if it's going to be public. You need to involve the medical statisticians early on. It's got to be trusted by clinicians and clinical teams, which means they need to be involved in deciding what's being measured and why. That data has to be timely. There's no point being years out of date before you get your data back. You need your data to be there in a timely fashion. It's got to be easy to interpret. The benchmarking data has got to be easy to look at and say, yes, I get it. Yeah. Collaboration is more likely to drive improvements than competition, I think, and for that, it's best to have lots of centres involved and lots of discussion. There is a role for process measurements. As I've tried to point out, that's what likely going to be essential. Well, that's going to be essential in terms of making the changes then to drive improvement. But teams are going to need the skills, the support, and the headspace to act on the findings. And it's a challenge driving improvement on the back of outcome measurements. So yeah, it can be done, but it's not easy. And that's my final slide. What I plan to do, this is value-based healthcare, and what I haven't discussed at all really is the costing arm of value-based healthcare. So I am going to hand over to Greg now, who is going to give a discussion, I think, just a verbal discussion. I think, Greg, your thoughts on, similar to benchmarking versus outcomes. I'd imagine the benchmarking against cost comes with challenges and has to be done properly and has to be trusted, I guess. So yeah, over to you, Greg.
Okay, thanks, Gareth, and thanks for the presentation. Just by way of introduction to everybody today, my name is Greg Bowen. I'm one of the Assistant Directors of Finance at Aneurin Bevan University Health Board, and the main element of my role covers the hospital divisions, which means that I'm sort of very much involved in value-based healthcare and various initiatives across our organisation. Obviously, the main body of the session today has been on outcomes and how we benchmark outcomes moving forward, but a key element of demonstrating true value across the system and pathways is also to look at costing as well. And what I want to talk about briefly today is how key it is to have really sort of robust costing mechanisms within our organizations, and in particular, in line with what Gareth discussed on outcomes, how we use it as well to be able to form conclusions and to drive future improvements. So in terms of what I believe to be some of the key factors in being able to arrive at the most accurate costing picture possible, what I want to try and focus on today is what I think to be some of the key enablers to do so. So I think, first of all, it's vitally important that our finance and costing teams are as close to the business, I guess, as possible, and working really collaboratively and proactively with both our clinical and operational colleagues, and getting that engagement together to really drive to the desired result that we need. What that allows us to do then is to really understand, the pathway, and that featured heavily in the slides so far today. So sometimes the key question is, how do we actually perform healthcare in this specific area? And if we follow that approach, I think what we're able to do then is to identify exactly how patients move through a pathway of a particular illness and condition, which lays the foundations then, I suppose, of being able to provide really robust and accurate costing pieces. Naturally, and especially if we're going to be looking at benchmarking maybe over time or in comparison to other organizations, we need really reliable and consistent data to allow such exercises. And I think that, provided that we've got those fundamental cultures and processes in place, then the costing element of pieces in terms of time and allocating cost to time, and maybe some perhaps some non-pay expenditure can be sort of relatively straightforward. And what that does then is it allows us to really able to analyse and benchmark costs, but as was featured earlier, really allow us to partner with our colleagues to identify areas for improvement moving forward. So once we've got that in place, I guess it's important then to discuss, I suppose, how we use that data to analyse performance, to benchmark, and also to drive those future improvements to really demonstrate that value. And I think that costing on its own probably doesn't give the full picture. We've talked about outcomes heavily today. I think if we look at costing, whether it would be benchmarking, over periods of time or to other organisations, it probably facilitates a number of key questions, but maybe not generate all the answers that we need. So, for all our kind of finance colleagues in the meeting today, then like all numbers, numbers on their own sometimes might not give the full picture, but it's really important to complement those numbers with the relevant operational data or the non-financial data and outcomes, so that we can use everything in conjunction to form that balanced view. And I think as well, linked into my point earlier about how closely finance, operational and clinical colleagues, can and should work together on this subject. It's very important then, I suppose, to use that kind of softer intelligence to form the basis of conclusions. So, there could be a change in a recent pathway, or there could be a temporary alteration to a pathway, that if we've got that sort of softer intelligence about what's actually happening on the ground, and we're all embedded in the service, then we're able to sort of pick that out really and help us to really sort of understand that and form that opinion. And I think in terms of the subject of driving value-based healthcare and benchmarking, if we've got robust costing processes in place, it also allows us to really work collectively across our organisations to identify any potential costs where there are improvement opportunities. So, for example, what wastage have we got within pathways that we can potentially eliminate as we move forward? And one of the things that I talk about quite often, just on a day-to-day basis, is we know that in healthcare time is very precious, and what time within our pathways and therefore cost have we got, which maybe we can look at in detail and we can conclude that it isn't contributing to the quality of patient care or the safety of patient care, and then how can we work together to either drive utilization potentially, or even just eliminate that cost in full, so that we can keep on emphasizing that value piece. Gareth alluded to it quite a bit as part of his presentation, but I also feel that when we're looking at costing, it's fundamental really to look at that whole pathway approach, especially if we're going to be benchmarking. I mean, we talked earlier around how sort of outcomes are measured over a period of time, and I think it can be quite dangerous sometimes to maybe look at part of a pathway or part of a treatment, and I think the value is demonstrated very much in the whole pathway and not maybe one part of a pathway or maybe what happens on one site. So I just wanted to give a quick overview this afternoon of how I think robust costing processes complement this overall picture, and the need for us all to work collaboratively together. That is it for this part from me, so I will hand back over to our host. Thank you.
Yeah, thanks, Greg. There's a question coming about costing, actually, who just ask this. What are the challenges around costing during the COVID pandemic, or the situation we find ourselves in now?
Yeah, I think quite an interesting subject, really, and I probably look at this in terms of like the challenges, and then maybe look at it in a bit more of a positive fashion in terms of how we move forward, really. So, look, I guess we all know where we've been in the last 18 months and largely where we currently are. And if we think about what's actually happened in terms of many of our pathways, if not all of them, there's been so many kind of staff redeployments, alterations and additions to pathways. It's been a real challenge to make sure that we've got robust processes in order to track them, Gareth, I think. And also as well, if we look at it in terms of some of the emphasis I put in when I gave my overview as well, we've also had the kind of physical challenge, really. We've not been able to be embedded in the service, I guess, as much as we would have done before COVID, and as much as maybe we'd like to do in the future. So it's been really difficult, I suppose, to sort of add some of that softer intelligence, and also as well, in terms of operational pressures, then really difficult to sort of be able to allocate some of that time, maybe from a clinical and operational perspective as well. So I guess that's some of the challenges in terms of trying to arrive at costing. And then when we think about benchmarking as well, especially if we're thinking about how do we benchmark over periods of time, what we have to remember, I suppose, right now is that there's been so many changes as a result in COVID. So we may have patients on a pathway that might have a higher acuity than what we perhaps would have had before the pandemic, which might drive a higher length of stay, or might require a higher specialism of care, which obviously adds to time and adds to cost. And I think that it's also important as well to really understand some of the, I don't know, what I would probably term specific COVID variables. So things like donning and doffing PPE, which wasn't here before the pandemic, and not just the time of doing that, but the cost of it as well, and having had to adapt to green and red pathways, for example, and the changes that would have driven. And it'll be interesting to see how things like that operate as we move forward. And there's also items such like additions to changeover times, for example, and having to clean and sanitize areas. All these issues drive extra time and drive extra costs. So if we're going to be trying to benchmark perhaps between previous years, for example, it's really important to understand that. But I think one of the things that we can do collectively, as we move forward and hopefully start coming out of the pandemic in terms of our restart and recovery agenda, is there were a lot of things 18 months, 2 years ago that we didn't think were possible, and COVID has forced us to make them possible. And it's really important, I think, to understand that we have to have agility, I think, in some of our processes when it comes to costing, and to really recognise that some of the additional changes that might or might not happen, to allow us to really be able to eliminate those variables, so we can have proper comparisons and benchmarking as we move forward. So an interesting topic, and certainly interesting to see how that develops over time. Thanks.
Yeah, thanks, Greg. There's a couple of questions coming through. Is there an example in Wales where benchmarking data has resulted in service change? I'm sure there are plenty of examples where national audits and process and structural type data have influenced practice. Obviously I'm not familiar with a lot of areas. I can certainly say in my own field of kidney medicine, we do have a lot of benchmarking data. We recently benchmarked our PROMs, our patient experience data, and that's been used as a basis to drive business cases and service improvements by showing differences between areas on patient experience and the need for different workforce in different areas. And we benchmark against various things. In terms of benchmarking against PROMs, though, we do collect PROMs in nephrology, but I don't think our data set is robust enough to draw any firm conclusions about who's doing well and who isn't doing well. For all the reasons I've said, really, you need big data sets to make firm conclusions. And again, across Wales, or even between Wales and other countries, I'm not sure if there are examples where we're currently at a state of maturity to confidently compare and benchmark on PROMs alone, especially in chronic disease. But maybe someone can type in the chat if they're aware of anything that's led to a direct service change, according to PROMs benchmarking in chronic disease. There was a question around, is there enthusiasm for, or is there resistance against international benchmarking? I certainly haven't come across resistance. If anything, it's enthusiasm that sometimes has to be toned down, because there's a risk of kind of benchmarking too early, almost before your data's at a state of maturity where you're in a position to do that. But there's definite enthusiasm, which is great, really, to not only have that mindset of we want to compare within Wales, we want to compare, nationally and internationally. I think that would be great when the data is robust enough to do that. I think that's it. We may be drawing to an end here, I think. So yeah, probably with a couple of minutes to spare, probably conclude the session there. I can't tell who's listening, but I'm assuming there's at least one person there. But thank you to whoever stayed on. Okay.